Hi, good morning everybody. I Dr. Rajesh Patil here. Today we are dealing with the pathology class as a part of online class schedule as per RGHS. So as you all know, I had started with the hepatobiliary system in the last class. So continuing with that particular class in this session. So today we'll be dealing with the organ liver, the mega magic organ that we all probably host, the liver. So we'll be dealing in this particular organ, different inflammatory conditions, different lesions like non-alcoholic steatohepatitis or diffuse parenchymal diseases, or it could be the alteration of its normal physiology leading to jaundice or various lesions, the storage disorders or the benign lesions, the tumors, the neoplastic conditions. It could be again the cirrhosis or the malignancies, the hepatomas. All these are very important not only clinical point of view but also from the exam point of view. Various questions could be in the essay type or a 5 marks question or 3 marks question can be asked on this particular topic. So before we go into the different lesions, diseases of this particular liver, we'll have a flash on basics, the anatomy, the histology, the normal physiology which we have already dealt in first year. So just to brush you up. Anatomy of the liver. The liver is the second largest organ of the body and the largest gland, weighing about 1 to 1.5 kgs. It is situated in the abdominal cavity beneath the diaphragm. It is divided anatomically by deep grooves into the large lobes, that is the right and the left, two smaller lobes, the quadrate and the caudate lobes. The liver physiology, so as you all know, function, it has got a dual function, the exocrine function and the endocrine function. So as you all know, it produces most of the circulating plasma proteins like albumins, very low density lipoproteins, the glycoproteins, the prothrombin, the fibrinogen. So various physiological body functions have a connect with the liver. Say for example, any bleeding tendencies. So even that's also linked to the liver because of its synthesis, its relation to the synthesis of these particular prothrombin and the fibrinogens. It secretes bile, it modifies the structure and function of many hormones like thyroxine, growth hormone, insulin, glucagon. The vascular supply, the hepatic artery, the right hepatic artery that contributes for about 25% of the oxygenated blood, and then the nutrient rich blood via the main important portal vein. So vein playing an important role here in this organ. So both vessels enter the liver at the porta hepatis. So again, we'll not go much into the details of this vascular supply. So this is normal the picture of these particular supplies. So we'll have a better diagrams in the coming slides than these ones, showing the hexagonal lobules, that particular veins, the hepatic artery, the normal supply. So this is again the histology. So how these central veins, the double cords of hepatocytes separated by the sinusoids. The portal area, that is the portal triad, contributed by these particular hepatic arteries, the ducts, the portal veins. So histology of the liver. So basically, this is again, contributed by this particular stroma, the parenchyma, and then the stroma is formed by this particular connective tissue, the trabeculae, the reticular network, whereas the parenchyma, as you all know, contributed by the hepatocytes, blood vessels, bile ducts. The liver lobules. So this again, as you all are aware, this is basically divided into classical lobules, portal lobules, and the hepatic sinuses. So this is again will not consume much of the time on this particular thing. We'll move ahead just to brush you up. So this is again the diagrammatic representation of this particular hepatic SNS between these particular the central veins, the classical lobule being at the center of the particular lobule, and then the portal lobule connecting the three central veins of three hexagonal lobules. So here in that particular triad is formed by again portal vein, bile duct, hepatic artery, which is away from the central vein of a hexagonal lobule. So all these are different physiological, anatomical, functional lobules. So hepatic sinusoids and the hepatic plates, the space of Dissay. So what is this? Basically it lies between the basal surface of the hepatocytes and the basal surface of the endothelial cells and the Kupffer cells. So there are small irregular microvilli that project from the basal surface of the hepatocytes into the space to increase surface area. Why you want to increase surface area? To increase the exchange of materials. So probability of the exchange increases with the increase in the surface area between the hepatocytes and the plasma found in this particular space. Perusinusoidal space, the space of Dissay. This space contains also the Ito cells. So we'll be dealing with what these basically the Ito cells are. The fetal liver, it contains islands of blood forming cells. The Kupffer cells, also called as the stellate macrophage. So this is a part of the macrophage system. So member of the mononuclear phagocytic system, they form part of the lining of the sinusoid. The processes of these Kupffer cells often seem to span the sinusoidal lumen and may partially occlude it. So again the functions, they play a role in the final breakdown of the damaged RBCs or the senile RBCs, and they also help in the removal of bacteria and debris that reach the portal blood from the gut. So these are very much helpful and partly improve your immune levels. The immunity contribution is done by these particular Kupffer cells. The Ito cells, the hepatic stellate cells, the fat storing cells. So these play an important role in deposition of a fat in the liver. So they have a mesenchymal origin found in the perusinusoidal space. They are the primary storage site of vitamin A here. They produce collagen 3 and growth factors required by the liver for the proliferation. So this is also called as the hepatic stellate cells, so the fat storing cells. So contribution of them towards cirrhosis, lose their lipid and vitamin A storage capability and differentiate into cells with characteristics of myofibroblasts. In case of cirrhosis we are talking here. Ito cells play a role in remodeling the extracellular matrix during recovery from the liver injury. Then the pit cells, the hepatic NK cells or large granular lymphocytes. So we'll skip out these particular and move ahead with the pace. So this is again the ultrastructure of these hepatocytes with the Golgi complex, bile canaliculi, space of Dissay, the rough endoplasmic reticulum, the smooth, the mitochondria, all are important parts of this particular cell. So coming to hepatocyte, this forms about 80% of cell population of the liver, the other being contributed by the stroma, the Kupffer cells, the Ito cells, all of the cells. Nucleus, there's a central spherical one. Most hepatocytes of adult liver are binucleated. See this important finding. So most of you all be aware that it is uninucleate. So but most hepatocytes of adult liver are binucleated. Has one or two nucleoli. Cytoplasm, generally acidophilic. So numerous mitochondria, numerous Golgi complexes. Lysosomes, important one here. Why? Because of the storage that it can exhibit in different ailments, different diseases of the liver. So this can contain lipofuscin pigments, that is the wear and tear pigment or the aging pigment, Partially digested cytoplasmic organelles, the myelin figures, they are the primary site for iron storage, increase in number in a wide variety of pathologic conditions. Glycogen deposits can also be seen here in these particular cell organelles, present as accumulation of electron dense granules. So the liver cells in the vicinity of the portal area, that is the zone 1, display large clumps of beta particles. On the other hand, pericentral hepatocytes, that is zone 3 of the liver, exhibit diffuse glycogen deposits. See, different storages in different layers of the liver, different areas of these particular lobules. They are abundant subsequent to eating and fewer after fasting. So that is how their performance is there before eating and then after consumption of the food. Lipid droplets, they contain mainly VLDL. They increase in number after fatty meals. Hepatotoxic substances causes increase of lipid droplets in the cells of zone 3. Hepatic ducts, that is the bile canaliculi, anastomose with one another forming labyrinthine tunnels among the hepatocytes. As these bile canaliculi reach the periphery of the classic lobules, they merge with cholangioles, short tubules composed of a combination of hepatocytes and low cuboidal cells and occasional oval cells. So we will not go into the very details of this. We'll just move on. This diagram, important one here, just showing you the canaliculi, the hepatocytes, how are they being separated. Histological structures, again the hepatic, cystic and the bile ducts. We'll skip out few of the slides here. Composition of bile, the important one. Basic composition of bile. Could be a 3 marks question. Water, phospholipids, bile salts, also called as bile acids, cholic acid, quinodeoxycholic acid. So bile pigments, so electrolytes, sodium, potassium, calcium. We'll move ahead here. Now what do you mean by liver regeneration? The amazing quality exhibited by this particular mega magic organ. The liver has a great ability to regenerate after hepatotoxic insult or even after a portion of the liver is excised. See this amazing function of this organ which is not there in any other organ of the body. The mechanism of regeneration is controlled by transforming growth factor alpha, transforming growth factor beta, epidermal growth factors, interleukin 6, hepatocyte growth factor. In most cases, the regeneration is due to the replicative capability of the remaining hepatocytes. So all these are the brief introduction. Now we'll start up with the diseases of the liver, and the most important easy disease that you can come across here. We'll begin with the liver cirrhosis. As this is easy to follow, I am beginning with this particular subheading of this topic, the hepatobiliary system, in that subheading the liver, and then comes the cirrhosis of the liver. So not only clinically is this topic important, but from exam point of view, invariably a 5 marks question. Cirrhosis. The term was first coined by Laennec in 1826. Many definitions, but common of them is the injury, repair, regeneration, scarring. So all these form a part of this. There is injury, repair, regeneration, followed by scarring. Scarring is ultimately the end stage of any inflammation. These particular tissues are replaced by the myofibroblast or the fibroblast or the connective tissue. This is not a localized process, involves entire organ. The primary histological features, what do you basically see here in a cirrhotic liver? Marked fibrosis, important points. Destruction of vascular and biliary elements. So after mark fibrosis, the destruction, then there is regeneration, regenerative nodule formations. So derived from Greek word kyros means orange or tawny, and os is the condition. WHO definition: a diffuse process characterized by liver necrosis and fibrosis and conversion of normal liver architecture into structurally abnormal nodules that lack normal lobular organization. See this diagrams, the healthy one, the healthy liver, and the cirrhotic liver. It has lost its normal shine, normal surface, regular surface, smooth surface is lost in cirrhotic liver. And this normal polished touch of liver is succumb to this nodularity, the fibrotic part that you can come across in case of the surface of the liver in cirrhosis. Causes of cirrhosis: alcohol, the most common; viral hepatitis, and in viral hepatitis again the hepatitis B, the Australian antigen, very common cause that is associated with cirrhosis when it comes to virus infections. Biliary obstructions, veno-occlusive diseases, hemochromatosis, Wilson's disease, autoimmune, drugs, toxins. See, drugs, so many of people consuming so many drugs. For just a fever, you consume paracetamol. For just body ache, myalgia, you consume aceclofenac or the diclofenac. Whatever drugs you consume, the first and the foremost impact is on your organ called liver. So just imagine, whatever you consume, you eat up the drugs. Metabolism is there in the liver. So impact directly is on the liver. So you want to heal your leg pain, impact on liver. You want to heal your head pain, impact on the liver. You want to treat the fever, impact on the liver. You want to cure liver diseases, the drugs, again metabolism in the liver. You want to cure disease of the kidney, disease of the pancreas, disease, everywhere the impact, major impact and the metabolism goes through this particular channel, the organ called liver. So the impact is huge when it comes to drugs and toxins. The metabolic diseases and then the idiopathic. Now coming to pathophysiology of the cirrhosis. The primary event is injury. Okay? Always remember this. The injury to the hepatocellular elements. So it initiates inflammatory response. What happens basically? Immediate release of cytokines, the toxic substances. See, any inflammation in any other body, there is release of chemokines, cytokines, interleukins, so all this. That's the reason you get fever in any infection, any inflammation. If you don't have cytokines, no fever. So you have fever, it's a good sign for you because it makes you know that you're ill and it gives you a guideline that you have to approach a doctor because you're not well from inside. So fever is a very good thing happening for us because it just shows, it's just an outside sign for an inside ailment. Any infection present with the fever. Why fever? Because of chemokine release, cytokine release inside the body. So there is destruction of the hepatocytes, the bile duct cells, the vascular endothelial cells. Repair through cellular proliferations and regeneration. And then ultimately, formation of the fibrous scar. Primary cell responsible for fibrosis is stellate cells. That is the key word. Highlight it. Stellate cells. Become activated in response to injury and lead to increased expression of fibril forming collagen. So this is again influenced by Kupffer cells which activate stellate cells by eliciting production of cytokines. So there is increased collagen and extracellular matrix synthesis. Prevents normal flow of nutrients to the hepatocytes. So when there is fibrosis, extensive fibrosis, it's obstructing the normal flow of nutrients and increases vascular resistance. Initially, fibrosis may be reversible when the these particular inciting agents are removed. With sustained injury, process of fibrosis becomes irreversible and leads to cirrhosis. See, any histological or the pathological change in a tissue can be reversed to some extent, to some at some stage. When that particular stage crosses, what is that stage? Formation of fibroblast, fibrous tissue, scarring. Once it's formed, it is irreversible. A fibrous tissue formed, stay formed. It can't be reverted back. It can't be reversed. So whatever you do, you have to do before the formation of the fibrous scar or the fibrosis. Now, classification of cirrhosis. WHO divides cirrhosis into three categories based on morphological characteristics of these particular hepatic nodules: the micronodular, the macronodular, and the mixed one. Now, coming to this particular micronodular cirrhosis. So, here the nodules are less than 3 mm, that's by definition itself, 3 mm in diameter, relatively uniform in size, distributed throughout the liver, rarely contain portal tracts or the afferent veins. Liver is of uniform size or mildly enlarged here. So it basically reflects the relatively early disease stage. So basically these are the, and then comes forward the macronodular cirrhosis and the mixed cirrhosis. So how are they different? Here the nodules are greater than 3 mm in diameter and very considerably in size. So usually contain portal tracts and the afferent veins. So liver is usually normal or reduced in size. The mixed pattern if both type of nodules are present in equal proportions. So basically micronodular, macronodular, mixed depending upon the size of the nodules, that is 3 mm plus, 3 mm minus. So this is again the schematic diagrams. So remember, schematic diagrams are always important for you in exams. It fetches you more marks. So always your answer should be added up with such schematic diagrams. Here, normal liver, lot of impact of the toxins or the exogenous agents or whatever leads to hepatitis. Then in the hepatitis there could be liver cell necrosis, inflammation, mammary body, fatty change, whatever. Or normal liver with the impact, with the exposure can leads to even the fatty change, the steatosis, that is left side, perivenular fibrosis. So ultimately both of these, when the exogenous impact, the agents are persistent, consistent on, and they are affecting, they are bombarding the liver continuously, then it finally leads to cirrhosis. Once it's cirrhotic, it can't be reverted back. It stays as cirrhosis. So whatever you want to do, whatever you want to remove the agents, you want to change the lifestyle. So at the stage of steatosis, fatty change, hepatitis, you can revert back when you stop your exposure to that particular harmful agents, toxins. Once you don't stop, you bombard your liver, you bombard your body with the same lifestyle, with the impact of these agents, and it progresses to cirrhosis. Now, alcohol-induced cirrhosis, also known as Lennox cirrhosis, important one. The single major contributing factor for the formation of cirrhosis is alcohol. So greater than 50% of patients with alcoholic cirrhosis die within 4 years of diagnosis. Oh my God, just imagine this. Within 4 years of diagnosis, how many die? 50% of patients who have cirrhotic liver due to alcohol. So once a fibrosis is formed in liver, it's gone case. So it's very, it has got very less chances that you revert back to a healthy normal liver. So it develops in only 10 to 30% of heavy drinkers. How much? 10 to 30% of heavy drinkers. Then what about the remaining 70 heavy drinkers? They don't have it. Why? Could be their body type, like, or genotype, their genetics. You can't ask a question, sir, that fellow has drunk so many these things, so high dose every day for last 10 years or 20 years. He's still hale and healthy. So I want to do the same. No, you can't do that. You might have cirrhosis. He may not suffer from cirrhosis. So basically, it also depends upon your genetics, how strong the genes you have. See, some people don't even drink anything, but they get cirrhosis. That is non-alcoholic cirrhosis. So this is all fate. There are some diagnosis or some things in treatment or in when it comes to health there wherein doctor has no answers. You just can blame everything or put blame on genes, genetics. You can just tell, I don't know, it depends on your genes. That's what happens here. 70% of other heavy drinkers don't suffer from cirrhosis, whereas 10% with moderate consumption of alcohol also can suffer from cirrhosis. See, basically, how how much you have to drink to have cirrhotic liver or risk factors, chances. 20 grams to 30 grams of alcohol on a daily consecutive basis for 10 to 20 years can develop cirrhotic liver. So if you consume one beer, two beer, less than that daily, you are not supposed to develop cirrhosis. That's the basic logic of a doctor or a health personnel, or your histology, your pathophysiology states you. But there is violation of such rules. If you drink even 10 grams a day, and then again you might yield up with cirrhotic liver. So, but generally, most of the times, when you drink 20 to 30 grams of alcohol in a day, or you consume this much over a prolonged period of time, remember, prolonged 10 years, 20 years, 30 years, only then cirrhosis can be developed in most of the patients. Okay. So as I mentioned here, multifactorial, genetic, nutritional, drug use, and even the viral. See, there are some patients who don't drink, don't do anything. Bloody hell, they'll land up with cirrhotic liver. Why? Never know. After screening, you might come across that they were HbSAg positive, the hepatitis B positive. So that might have led to this particular development of the cirrhotic liver. So if you're non-alcoholic also, but if you are getting infected with hepatitis B, it's very risky. But hepatitis B, there are so many survivors who die along with hepatitis B rather than due to hepatitis B. So unless the core antigen comes into play here and your liver is destroyed. The famous personality Amitabh Bachchan suffers from hepatitis B, but still he is hale and healthy. His liver is still very much functional and healthy to support his life. So it all depends. So this is again the diagram of this particular nodularity, the histology here of this particular cirrhotic liver, the small, extensive fibrotic scars, the fibrous tissue deposition in that particular histological part. So this is again the normal liver, the cords of these particular hepatocytes, the cirrhotic liver, wherein there is nodules being the lobules are limited by these fibrous septas being formed there. So this is again the high resolution there. Okay. So what's the diagnosis? How you diagnose this particular cirrhosis? The gold standard for the diagnosis is again, basically the biopsy. That's the basic gold standard. Lot of symptoms the patient can come across, and you can, he might suffer from esophageal varices, he might suffer from bleeding per rectum during passage of stools, or caput medace. So you can have the presentation, the engorgement of these particular capillaries on his chest wall, around the umbilicus, and some spots on his back. So all these ailments. So we have to do liver function test in such people. The raised LFT levels, the serum proteins levels, the albumin level,